Laparoscopy has a long curve, but hysteroscopy, every gynecologist should try to learn and do. That is what I feel. And from this podium, I must say I'm missing Dr. Neeta Parashar Madam, Dr. Rakhi Vajpayee, Roma, and my dear daughter-in-law, Richa. I think everyone is missing. Am I right? So, to begin with, see inside and heal inside has to be our motto. There were the days when we can only palpate uterus. Decide if the uterus is bulky, we cannot differentiate between adenomyosis and fibroid uterus. And sometimes, if there is no history of amenorrhea, we think we cannot rule out pregnancy also. Then comes the era of sonography, and we start seeing the image of uterus. And in modern era, you can enter inside the uterus and see millimeter by millimeter by an instrument called hysteroscope. See and treat is now our concept. If a patient comes to you with the sonography finding of endometrial hyperplasia with menorrhagia, one gynecologist offers DNC. She is continuously bleeding profusely and her symptoms are not relieved and end up in hysterectomy. But if we try to do hysteroscopy and then we found a polyp, a simple hysteroscopic resection of polyp relieved her symptom and we are able to save a uterus. So, hysteroscopy is a better option rather than doing blind DNC. And we have to offer right choice to every patient. FIGO and GCH joint consensus says that higher rate of complications such as uterine perforation, cervical lacerations and bleeding is with DNC. DNC has inability to accurately diagnose the type and extent of intrauterine pathologies which can result in incorrect or incomplete treatment. Higher rate of incomplete removal of intrauterine lesions such as polyp, fibroid, retained product of conception, leading to need to perform multiple procedures. And there is a limitation of management of complex intrauterine pathologies such as Asherman syndrome, congenital uterine anomalies, and caesarean scar defects, and even scar ectopics. If a girl comes to us with menorrhagia, so it is very difficult to do DNC. And in a patient, elderly patient, postmenopausal, with some intrauterine pathology with previous 2 sections or 3 sections, uterus is acutely anteverted with high cervix, flushed with vagina. So DNC is a very difficult process. So in today's world, where DNC could not enter, hysteroscopy walks with grace and simplicity. But safe hysteroscopy is very important. Every gynecologist should embrace hysteroscopy in practice, prevent complications, and then master the procedure. So, uterine perforations are very, very rare complication if we follow uterine anatomy. Fluid overload and air embolisms, they can bother us because they can come unexpectedly. Hemorrhage, bladder and bowel injuries are now history and they are very, very rare. RCOG study says that complications are because of improper knowledge of anatomy. Always do bimanual examination before doing procedure. Follow proper fluid management protocol and understand safe entry. Knowledge of instrument and knowledge of human physiology is important. To prevent air embolism, which is a very dreaded complication, never give Trendelenburg position. Remove all the air from your tubing system. Never introduce needle in the bottle. And repeat insertion and extraction of resectoscope can block the channel and allow air to pour in. So we have to follow basic anatomy and physiology of uterus. Uterus is a very small pear-shaped organ with a inverted triangular cavity, and the length of the nulliparous cavity is between 3.5 to 4.5 centimeter. The thickest wall is at the fundus. The ostia are very thin, about 4 millimeter, and the thickness of the lateral wall is between 7 to 9 millimeter. With distension media, the thickness can be reduced by 30 to 50%, but in perimenopausal and postmenopausal women, this because of the hormonal changes, the thickness of the uterus again goes down, and these are the women in which there are chances of perforation if we are not careful. Never dilate. When we have started doing hysteroscopy, we used to dilate. I think everyone was doing, but now it is always better not to dilate, because after dilatation can cause false passage, debris and blood clot comes in the view and decreases vision. So correct way is without putting speculum, do vaginoscopy, follow the mucosal fold, and you can see cervical os, beautiful oval shaped cervical os, 4 millimeter. And when we follow the mucosal fold, we can see some mucus coming out from the cervical os, and then when we enter, we see beautiful inverted triangle uterine cavity with 2 ostia. They are mirror image of each other. One is if at the 3, the other is at 9. And when we come down, we can see the lateral wall. And when we follow these mucosal fold and this technique, it is very difficult that you can perforate uterus. So, if you don't do by this method, put the speculum, catch the anterior lip, but never dilate. So, in the first picture, we are seeing the ostia, but the fundus is not in umbrella shape. So, this is a partial septum. And we have to cut this septum with the scissor, not with the energy source, if fertility is required, because energy source can hamper the endometrium. If you only see one ostia, at the 12 o'clock position, it is either the unicornuate uterus, or you are in one cavity of bicornuate uterus or complete septate uterus. And if you see multiple ostia like this, these are our creations. These are iatrogenic. So to avoid this, do not curate till the gritty sensation. Otherwise, the adhesions will form and patient may go into Asherman syndrome. Do not play with the physiology of the human body. Hysteroscopy is a surgery in which we can change physiology of the human body within minutes. We can change pH, temperature, electrolytes, and we can cause fluid overload. All of us can fight against disease because our physiology is important and take care of us. But if we change the physiology by doing wrong hysteroscopic procedure, not taking care of pH and electrolyte, then there is nobody can save us. So it is very important to do this procedure cautiously. Fluid dynamics in hysteroscopy. Never dilate. Dilatation can cause false passage. ये तो मैं बता चुकी हूँ. I think I am repeating it. So the pressure to visualize cavity, required pressure to visualize cavity is 70 mm of Hg. The ostial opening starts at, we require 45 to 55 mm of Hg pressure to visualize the cavity. Ostial opening starts at 70 mm of Hg and we require 50 to 200 ml per minute flow to do small procedures. But everybody should know what is fluid deficit. Actual inflow minus actual outflow is the fluid deficit. So the anesthetist, the surgeon and the assistant present in OT look for the fluid deficit. We start with the pressure of 100 mm on endomet. Mean arterial pressure is between 80 to 90 mm of Hg, and whenever this pressure goes above 90 mm of Hg, excessive peritoneal fluid absorption starts and it is going into the system. So for diagnostic hysteroscopy, 50 ml per minute flow is required. For operative procedure like polypectomy and septum resection, 200 ml per minute. But for submucous myomectomy, 300 ml per minute pressure is required. So if there is a big myoma and you are doing myomectomy with resectoscope, it is better to abandon the procedure and do second look and repeat it rather than causing overload for the patient. यदि एक 3 लीटर की बॉटल 3 मिनट में ख़त्म हो जाती है तो ये एक डेंजर साइन है. कुछ तो गलत हो रहा है और हमको वो प्रोसीजर रोकना पड़ेगा. So if we are doing procedures like complete septum, like myomectomy, the anesthetist has to be alert, you has to be alert, and the assistants has to be alert. So the fluid flow rate should increase 250 ml per minute if we are doing myomectomy. If endomet is not there, then you can use TURP set with 2 bags. Because if there is only 1 bag, then there is a time lag. You have to take it out and then reconnect. And in this time lag, air can enter into the system and can cause air embolism. Now the importance of distension media. Previously, when we are doing electrosurgery, we were using glycine. But normal saline and ringer lactate are low cost, easy to obtain, has electrolyte, and their osmolality is closer to blood. So the only bad point is they conduct electricity. So always use normal saline with bipolar energy source. Don't use glycine. Why we should not use glycine? Because it is electrolyte free and hypoosmolar fluid. Glycine enters the cell by virtue of osmosis and bring water intracellularly, causes cellular edema, causes electrolyte imbalance, and elimination of glycine primarily occurs in liver yielding ammonia, and glycine is an inhibitory neuromuscular neurotransmitter in the retina. So there are chances of temporary blindness. हम मरीज को ऐसा नहीं बोल सकते कि सर्जरी तो बहुत अच्छी हुई है पर 2 दिन तक तुमको दिखेगा नहीं. So no to glycine. Collect all. These are the simple bags we have to put under the buttock of the patient. It collects all the fluid so we can measure the fluid deficit. Energy in hysteroscopy, mechanical is safest. Do not use monopolar. Bipolar is safe. So always use bipolar energy. Small was always beautiful and effective too. You cannot go back and change the beginning, but you can start where you are and change the ending. So, start buying small instrument and improve your skill of hysteroscopy. Telescope 2.9 millimeter, sheath 5 mm Bitoki, and resectoscope 22 to 26 French bipolar is ideal. To begin with, start with 50 diagnostic procedure, start with simple polyp and small septum, and then gradually progress and start submucosal myomectomy. Hysteroscopy is stethoscope of gynecologist and make every gynecologist complete. You can upscale your skill at any stage of life. You are never too old to learn. This is a case of secondary infertility with multiple bone inside the uterus. हमारी निकालने वाला वो उसने वीडियो रिकॉर्ड किया ही नहीं है. The end result is we have removed all the bony pieces from the uterus and we are waiting her to conceive again. In the second jodi diya, this is a post-operative uterus after removal of the bony pieces. मिश्रा जी कहाँ गए? दूसरा कहाँ गया? खत्म हो गया? पता नहीं. नहीं है, पता नहीं. आगे है मिश्रा जी दूसरा वीडियो. वही आ रहा है. आगे बढ़ाओ. पॉलिप वाला नेक्स्ट आएगा. पता नहीं, देखते हैं. This is a small polyp causing menorrhagia. Hysteroscopic removal of this polyp done by the Caesar and patient is relieved. नेक्स्ट दिखा दो छोटा सा एक और. नेक्स्ट चल जाने दो. So fortune favors the prepared mind. Thank you so much.